Airspace opacity and consolidation that occur in the upper lobe, or it can occur in lower lobe, middle lobe, whereas and it results in increased parenchymal density that obscure the visibility of the vessel and the bronchial wall. It can be due to edema that involve the fluid, infection that involve the pus, or it can be due to diffuse pulmonary hemorrhage. Diffuse pulmonary hemorrhage further involves, or the example of diffuse pulmonary hemorrhage are Goodpasture syndrome, Wegener's granulomatosis, idiopathic pulmonary hemosiderosis, microscopic polyangiitis, SLE that is systemic lupus erythematosus, Behçet disease. It can be due to contusion. It can be due to bleeding diatheses that involve the continuous flow of the blood or some bleeding disorder or pulmonary infection. Now further, we will see the further DDs involve malignancy, sarcoidosis, chronic eosinophilic pneumonia, organizing pneumonia, and lipoid pneumonia. Malignancy can involve adenocarcinoma or lymphoma. The malignancy of the lung mainly are due to adenocarcinoma or lymphoma, sarcoidosis that consists of an airspace pattern that can be seen in up to 20%, and it is due to filling of the air spaces by macrophages and granulomatous infarction or infiltration. Chronic eosinophilic pneumonia, it can be non-segmental. It involves mainly the upper zone, predominantly, or peripheral. Upper zone, periphery, or it's mainly parallel to the chest wall. Organizing pneumonia are involve cryptogenic or due to some infection, drug, toxicity, or connective tissue disorder. It involves the lower zone, mid or lower zone. It's only unifocal and consists of a reverse halo sign. That involve a halo that is covered by consolidation, dense area. Lipoid pneumonia involve aspiration or ingested or inhaled oil, a consolidation that tend to be basal and has attenuation that is close to fat. So it's similar to the fat density. The next, it can be a consolidation can occur recurrent or it's non-resolving, that doesn't resolve, keep on coming again. So it further non-resolving or recurrent consolidation DDs include bronchial obstruction, inappropriate antimicrobial therapy, malignancy, recurrent aspiration, pre-existent lung pathology, impaired immunity, organizing pneumonia, sarcoidosis, vasculitis. Bronchial obstruction is caused by any foreign body or a tumor. Foreign body, mainly in children they inhaled any foreign body. So foreign body or a tumor. Inappropriate antimicrobial therapy occurred in unsuspected TB, Klebsiella, or fungal infected person. Malignancy, adenocarcinoma, and lymphoma. Recurrent aspiration, that is due to pharyngeal pouch. It can be occur due to eclasia. It can occur due to tracheoesophageal fistula. There is a trachea and esophagus, a hiatus hernia, or a pharyngeal pouch cleft, or a chronic sinusitis. Pre-existing lung pathology, that's bronchiectasis. Impaired immunity, that are patients who are prolonged on steroid therapy or they are immunosuppressive, patient having diabetes, HIV, organizing pneumonia, sarcoidosis, and vasculitis. The other is migratory consolidation, transient airspace opacity that change in location over time. So DDs involve organizing pneumonia, recurrent aspiration, pulmonary eosinophilia, pulmonary hemorrhage, infarcts, consolidate vasculitis, or alveolar proteinosis. Organizing pneumonia occur mainly in the peripheral, mid, or lower zone distribution. Recurrent aspiration occur in lower zone. Pulmonary eosinophilia, that can be simple pulmonary eosinophilia that involves Loeffler syndrome that resolves spontaneously within 1 month, or chronic eosinophilic pneumonia that persists for several months, and they involve upper zone distribution. Upper zones are involved. The next is consolidation with an enlarged hilum. These are hilum, and this is a consolidation. Hilar lymphadenopathy may be secondary to pneumonia, or pneumonia may be secondary to bronchial obstruction, and they are caused by hilar mass. So secondary pneumonia can be segmental or lobar consolidation. There is slow resolution, reoccurrence occur, and it is associated with volume loss and lobar collapse. So it involves TB. TB cause lymphadenopathy unilaterally in 80%. It involves HILA or paratracheal lymph nodes. Then viral pneumonias. Next, mycoplasma pneumonia that occur mostly in children. Mycoplasmas occur in children, and they can be unilateral or bilateral. Primary histoplasmosis, they are common in endemic areas, and hilar lymphadenopathy is common. They are particularly in children, and on healing of the lymph nodes, Lymphadenopathy occur, the lymph nodes are enlarged. When they heal, they result in calcification. These calcific foci then obstruct the bronchi and result in formation of bronchiolith that then cause distal infection. Last, coccidioidomycosis that also occur in endemic area, and this consists mainly of lower lobe consolidation with hilar lymphadenopathy.